Hi, my name is Caitlin McNamara, and I'm a senior at the University of Kentucky. I am a Spanish and neuroscience double major, and today I will be doing a short talk on cerebral palsy. So let me just click out really quick. All right. So you all may be wondering, what is cerebral palsy, and why did I choose to select this particular topic? In the past, traditionally, I've done research topics and discussions on traumatic brain injury because I've done research in TBI. But today I wanted to kind of change focus and look at a different disorder called cerebral palsy. And that is because when I was in Ecuador this past year in August and in March, I was a medical interpreter for a group of physical therapists that went down to work with children that had developmental delay. And that included children with cerebral palsy. And as I was interpreting, I wondered, these topics, I wondered more about what is cerebral palsy. And it becomes very difficult to interpret if you don't really know what it is you're trying to explain. So, hence this particular research topic. So let's get started. So first of all, what are we going to be covering today in this lecture? First of all, I'm going to give you a little neurological perspective. So what parts of the brain are we talking about? What neurotransmitters are we talking about? What does a normal brain look like? And sort of review of our neuroanatomy just a little bit. And then we're going to look at what is cerebral palsy, shortened to CP. Then we'll look at a little bit of the history, so how long has CP been around? Epidemiology, so the occurrence and prevalence of cerebral palsy here in the United States and around the world. And then we're going to look at a description and a presentation of the signs and symptoms of cerebral palsy. Then how it is diagnosed, the risk factors that may lead to cerebral palsy, the types of cerebral palsy. So I will be covering 3 distinct types. Their clinicians have characterized more, but these 3 distinct types correlate directly with specific parts of the brain, which is why I'm going to be covering just those 3. And then we're going to be looking at the prognosis. So what can a child with cerebral palsy expect in their future life? And then what are the treatment options? There is no cure for cerebral palsy, but what treatment options would a patient have? And then also just touching on the current research. So now looking at our neurological perspective, what is going on in the brain? So here we have a couple of basic pictures of the human brain. First of all, I need you all to be thinking of what is the major inhibitory neurotransmitter in our nervous system. If you don't know the answer to that, it's GABA. And what about the major excitatory neurotransmitter? Well, at least in the neuromuscular junction, that is acetylcholine. So keep that in mind as we go along in this presentation. That'll be important later when we discuss certain aspects of cerebral palsy. You need to remember that the major inhibitory neurotransmitter in the nervous system is GABA, and at least for our purposes in discussing the neuromuscular junction, acetylcholine is the major excitatory neurotransmitter. So let's look at the brain over here on the left-hand corner. Here we see with the many colors is the cerebrum, what we typically think of as the brain. Below that in the cayenne blue is the cerebellum, also known as the little brain. And then right below that is the brain stem. So the cerebrum typically deals with higher order functions, sensory input. The cerebellum, we look at coordination of motor movements, and then when we get down to the brain stem, that's sort of the lower involuntary functions, breathing, heart rate, swallowing, those types of things. So if you look at our frontal lobe over here in the light pink, that deals with executive functions, planning, organizing. We also look at that as the dopaminergic or the dopamine reward system. The temporal lobe in memory, think of Broca's area, Wernicke's area, so language. And then if we move over to the occipital lobe, which deals primarily with vision, then over to the parietal lobe, which deals with integrating all the sensory information that we receive and making sense of it. And so it allows us to sort of gain a larger picture of the world around us. And then also arithmetic and spelling, but those seem to be secondary. But what I also want you to focus on is the presence of the motor cortex and the sensory cortex, especially the motor cortex. So with cerebral palsy, what are we looking at? What deficits can we expect to see, and where would they be in the brain? And that will specifically be here in the motor cortex with voluntary movement control, then down to the cerebellum with coordination, and then although you can't see it in this picture, there's a central part in the brain known as the basal ganglia, and that we've linked with other diseases such as Parkinson's. So if you think of tremors, the tremors that exist in Parkinson's and the difficulty with movement, so it's not hard to sort of make that connection between cerebral palsy and the tremors in the basal ganglia. So that's basically what you will need to remember as we go through this presentation. The basal ganglia, the cerebellum, the motor cortex, and also the cortex in general, looking at gray matter versus white matter. So what is cerebral palsy? So if we break down the name cerebral palsy, cerebral meaning having to do with the brain, and palsy meaning weakness or paralysis, but palsy in itself can also be sort of misleading because it's not paralysis like you would think of Christopher Reeves after he received a spinal cord injury. It's more thinking about the spasticity, the dystonia, the lack of tone, hyper or hypotonia in a human being that has cerebral palsy. That's what you really think of when you think of this palsy or the weakness associated with it, not so much complete paralysis. But essentially it is an umbrella term that refers to a wide range of motor deficits that are due to the fact that the central nervous system did not develop correctly. It is a spectrum disorder, and what I mean by that is that there are some people that are affected by cerebral palsy and they really suffer no major motor deficits. They're not as impacted by it. But then you have people on the other end of the spectrum that have difficulty moving and will need therapeutic intervention for their entire life. So let's look a little bit more. What is cerebral palsy really? So looking at the history of CP, we know that it was first characterized in 1843 by Dr. William Little, and he hypothesized that the reason that cerebral palsy occurred was due to problems with the birthing canal, the actual birthing process, and that the child was somehow deprived of oxygen while being born. Now, we know today that that accounts for less than 6%, that oxygen deprivation in general accounts for less than 6% of all cerebral palsy cases. But interesting that he had come up with that initially. And then if we move on to 1897, we see that Sigmund Freud, the Dr. Sigmund Freud, before he really came into his psychological theories, he thought, or in looking at children with cerebral palsy, he found that a lot of the cerebral palsy patients didn't seem to suffer from any mental retardation or cognitive deficits. So he thought that it was probably due to some sort of developmental delay in utero or during development, that there were some neurological deficits occurring during development, and that it wasn't something during the birthing process. Which is also, in fact, an important point to make now, is that a lot of people that have cerebral palsy don't necessarily suffer from mental retardation. Severe cases of cerebral palsy, you typically see mental retardation, but many people lead very normal lives with cerebral palsy and have complete cognitive function. Then their intelligence and IQ is completely intact. So let's look at the epidemiology. The prevalence is about 2 in every 1,000 live births, but if we look at preterm infants, we see that number increase to 86 per 1,000. So we see that this is an important risk factor for cerebral palsy. Preterm infants, low birth weight infants, typically have a higher prevalence of cerebral palsy. So as you can see, about 5,000 new cases per year in the United States. Spastic cerebral palsy is most common, resulting in about 80% of all cases. And within spastic cerebral palsy, there are actually 2 major types. One is spastic quadriplegia and spastic paraplegia, And those are important to remember here in a second, and I'll explain them further. There is current research by Oding, 2006, in the United Kingdom that is looking at possible socioeconomic factors that may affect rates of cerebral palsy. So They looked at families from affluent neighborhoods and their prenatal care versus families from poorer areas and their prenatal care, and looked at the rates of cerebral palsy, and they found that there was about 3 per every 1,000 live births in the poor neighborhoods or poor families, and that the rate was actually lower, about 2 every 1,000 live births for the affluent. Now, with this particular research, there was no p-value indicated, so I would like you to keep that in mind. So, description and presentation of the condition. So what are some of the signs and symptoms? As a concerned parent, how would they know whether their child might have cerebral palsy or not? So it's important to note that there are several motor milestones within the child's first years of life, and it is important to be observant of those milestones in case the child may not be reaching them or may be having difficulty with them. So if a child exhibits difficulty with posture, reflexes, crawling, maybe they favor one limb versus another, maybe they favor one side of their body versus another, could be indicative of cerebral palsy. It is a persistent qualitative motor disorder, which means it will exist throughout the person's life. However, it is not progressive and it is non-communicable. So what I mean by not progressive is that it will not continue to degenerate or deteriorate the nervous system. As the nervous system is right now, it suffered deficits or problems in development, but it will not continue throughout the person's life. However, that does not mean that there are not symptoms that are latent that will show up later on in life, or that symptoms may not worsen over time. It just means that it's due to the body's development, not the neurological aspect of that. What's important to realize as well is that children are at risk for developing cerebral palsy from the time that they're in utero until 3 years of age. So there's a critical period in which if a child is, if a specific risk factor is induced in this time, that they could develop cerebral palsy. And we'll look at that in just a second. So there are 3 main types of cerebral palsy, and this is where it will be important to remember your 3 brain regions, the basal ganglia, the cerebellum, and the cortex or motor cortex, because the 3 main types correspond to these 3 main regions. So we're thinking about here the basal ganglia. Well, that is directly correlated with athetoid cerebral palsy, and then ataxic cerebral palsy is directly correlated with problems with the cerebellum, and then spastic cerebral palsy is directly correlated with problems in the cortex and the motor cortex. It's also important to realize that cerebral palsy may not affect the entire body, so it could be that it affects in a paraplegic fashion, so half the body from just the arms or just the legs. Hemiplegia refers to the fact that if you were to divide the body in half, you would look at like an arm and a leg on one side may be affected and the other not. And then quadriplegia refers to all 4 extremities, so both the legs and the arms. So there's a wide range of symptoms and impairments that may occur due to cerebral palsy, and also that's dependent on how severe the case is. So in terms of motor deficits, there could be issues with, again, with posture, reflexes, motor control, coordination. We're also looking at possible secondary symptoms, so just because those parts of the brain were affected, it could also mean that other deficits might occur. So for instance, if a mother were to sustain or catch rubella during pregnancy, rubella is German measles, and it can often cause impairments in the growing fetus. And it is one of the main risk factors for cerebral palsy, but it also is a main risk factor for vision problems. So a child with cerebral palsy may in fact also have vision problems. They could have problems with swallowing, with speech. And if you think about it, it makes sense because there are muscles involved in articulation, in movement of the jaw, and mastication. So that's altogether reasonable. There's also issues with urinary incontinence and also perception. Just basic sensory perception can also be altered. Also, it's important to realize that because the motor deficits occur, also may affect the skeletal development. So the skeleton, as the child grows, relies on the resistance of those muscles. And if they're not adequate, or if they're weakened or spastic, it will also alter how the skeleton will develop. So in children with cerebral palsy, typically there's fragility of the bones. They may break more easily, or they may come out of their joint socket more easily. Also, because of cerebral palsy, the joints and the cartilage degenerate, and so those joint spaces narrow over time and may cause pain. There's also a possibility for having osseous deposits in areas where the muscles are not properly toned. So again, it's important to realize that cerebral palsy has many different types of symptoms and impairments. And among those impairments, just within motor control, we look at dystonia, spasticity, and tone. And also it's important to remember, as I've said before, that cerebral palsy doesn't necessarily imply that there will be a cognitive deficit. In fact, many people have cerebral palsy and have their intelligence or IQ and it's totally intact. It's not affected at all. So here's a couple milestones suggested by the CDC that if the child reaches 2 months of age, 6 months of age, 10 months of age, etc., that if they have not reached these particular milestones, that it may be important that the parents take the child to a physician to be examined. So, for instance, if a child at 12 months of age is not crawling or can't stand without having support, that may be a red flag that the child is suffering some motor deficits. So all of these, as you see here, are important. And as you see up here, the child over 2 months with cerebral palsy might have stiff legs that cross or scissor when picked up. This is an important signal for cerebral palsy because children with cerebral palsy often have distorted gait, and one of the types of distorted walking patterns or gaits is called scissor gait, and that's where they cross their legs. So if you already start to notice the scissor pattern in the child at 2 months of age, it may be a red flag that they could have cerebral palsy. So then how is cerebral palsy diagnosed? In very severe cases of cerebral palsy, it may be able to diagnose when the child is first born. Typically they'll have microcephaly, which is a small skull. They also may have a distorted spine or curvature of the spine. So those are important indicators of possible presence of cerebral palsy or motor deficits. Also, a low APGAR score or infant jaundice may be indications that the child could develop cerebral palsy later on in life. But if none of that happens, how would a parent or a clinician diagnose cerebral palsy? So it's up to the parents to really notice those motor milestones up front, and once they notice those deficits, to take their child in as soon as possible. The child should already be going in for monthly or yearly checkups on a regular basis to check for overall health, but it may be important to see a specialist if these motor deficits are detected. So right now there's no blood test or genetic test that can, and there's really no genetic basis for cerebral palsy, so there's really no clear test that can say whether a child has cerebral palsy or not. So there's no definitive test, but what a clinician will do, especially a specialist, will look at how the child ambulates, plays, how they move, their posture, if they're able to support themselves, similar to those motor milestones that the parents may have noticed. They'll also go over the medical history of the child, and they may do a functional MRI or diffusion MRI, which is DTI, and that looks at diffusion of water fluids through tissues, especially in the brain, and you can see if there are any white matter changes within the brain, which a deficit in that may also be indicative of cerebral palsy. So what are some risk factors? What causes cerebral palsy? Well, it's important to point out that there is not one singular cause of cerebral palsy, and even a mix of the symptoms or a mix of the risk factors may not cause cerebral palsy directly. A person may have infant jaundice or a low APGAR score and never develop cerebral palsy, but these are all risk factors that have been connected with the onset of cerebral palsy. So in utero, we have intrauterine exposure to viruses. As I've mentioned before, There's rubella, which is German measles. Complications with pregnancy, so thrombosis or pregnancy-induced hypertension, which may cause toxicity to the child. Multiple births, which kind of connects with preterm or low birth weight, because typically with multiple births you have preterm children or children of low birth weight, especially among triplets or twins. There's also the factor of oxygen deprivation, which we've already discussed is probably less than 6% of the cases. There's also the RH factor incompatibility. So if the mom is RH plus and the child is RH negative, it's possible that that would cause complications in the pregnancy. After birth, this is very interesting. So we're looking at what may occur to the child outside of the womb. So severe infant jaundice, buildup of bilirubin, complications with oxygen at birth and the deprivation resulting. This is very controversial because many parents would like to blame OBGYNs for the child's CP, saying it was a problem in the birth, but as we know, oxygen deprivation accounts for less than 6% of cases, so this is actually a controversial issue. Preterm or low birth weight, low APGAR score, head injury or stroke, so TBI, shaken baby syndrome, or an ischemic attack. And then we're looking at possibly viral infection, so encephalitis, meningitis in the child may induce cerebral palsy. So what are the three types of cerebral palsy? And now we're going to go back to the three brain regions that we discussed before. With spastic, again, we're discussing or thinking about the motor cortex and the cortex overall, the gray matter. This is the most prevalent type, and as I said before, there's quadriplegic or spastic quadriplegia and spastic paraplegia. Spastic quadriplegia is the most severe type as it affects the entire body, and typically with those patients, they present with vision problems, speech problems. They may suffer from the mental retardation that we've discussed before, and overall they're going to have a very difficult time moving. The problem with spasticity is that if it goes unchecked or untreated, it may result in contractures, and contractures often cause the limbs to, well, as they sound, contract, and it's very difficult to move them out of that once they have become in that sort of frozen state. There are surgeries that can relieve the pressure, but they're not ideal to this situation. So what is spasticity? It's basically it's hypertonia, and it's overexcitation of that excitatory or acetylcholine in the system without the positive effect of the GABA. So remember I told you that acetylcholine is the excitatory neurotransmitter in the neuromuscular junction, and then you have GABA, which is the inhibitory. Well, if acetylcholine is constantly activating these areas in the muscle will contract in response. But if there's no GABA to inhibit it, then the muscle has a difficult time relaxing. So what you have is a constantly contracted muscle. And so a lot of times with children that have spastic cerebral palsy, they'll induce a muscle relaxer, which in fact is either a GABA derivative or enhances the effect of GABA to help. There's also the fact that dystonia may occur, and dystonia essentially is spasticity generated by, or activity-dependent spasticity, if you want to look at it that way. So a child may be able to move or ambulate normally, but given a certain action or activity, the spasticity sets in. So let's say if you were to start running and then stop and walk, and that change from the activity of running to the activity of walking will start or elicit the spasticity, the dystonia. Then there's athetoid, and as we discussed before, it's due to damage in the basal ganglia. And athetoid cerebral palsy is basically the result of a mix of hypotonia and hypertonia. So you have hypotonia with which results in flaccid, weakened tone of the body, and then you have hypertonia, which is that spasticity. So a child with athetoid cerebral palsy may find it very difficult to complete simple tasks such as scratching your face or brushing your teeth. And that's where you think of Parkinson's disease with those tremors. It becomes very similar, where the mix of hyper and hypotonia creates sort of tremor-like movements, and the child has difficulty moving. Then there's ataxic, and that's due to damage in the cerebellum. So if you think of someone who is drunk and they have difficulty with hand-eye coordination, motor coordination, it's similar for someone who has ataxic cerebral palsy, and that they have difficulty making those smooth motor movements. They may have difficulty with balance or walking, but that's typically with ataxic. Again, spastic is the most prevalent. Athetoid and ataxic are less prevalent. So it really takes a village, though, to help with treatment for kids with cerebral palsy. And so we're going to take a look at how can we mitigate the symptoms of these children. So there is no cure for CP. There are treatments, however, through physical therapy, occupational therapy, speech therapy, surgery, medication, biofeedback, all of these can help mitigate symptoms. For some children, as I discussed before, cerebral palsy is not profound, and so they can live a normal life with very few complications or little therapeutic intervention. And then there are some kids that require therapeutic intervention for the rest of their life. Most people with cerebral palsy survive into adulthood. The rate of that mortality will decrease after 15 years of age. And the most common cause of death, though related to CP, is respiratory disease, because children with CP have difficulty in the musculature of the upper respiratory tract. And this was something that we saw quite a bit in Ecuador, where I was working with children, is that they had a lot of upper respiratory diseases and difficulty breathing. So this was definitely a symptom seen among children with severe cases of CP. So what are some treatment options? So with physical therapy, occupational therapy, and speech therapy, all of these help to mitigate symptoms of spasticity, of movement. They provide orthotics or wheelchairs or abilities or ways to communicate with others. Occupational therapy can help a child to ambulate in their environment, so completing actions such as dressing themselves, climbing into bed, brushing their teeth, eating. All of those are examples of occupational therapy. Physical therapy, on the other hand, may provide exercises or ways to help calm spastic muscles or stretch areas that have started to contract or form contractures. They also may provide orthotics or DAFOs. Wrist splints are also another way to help sort of stretch the forearm. DAFOs a way to stretch the lower leg. And then if you look at speech therapy, it's a great way to help children who have difficulty swallowing or may have difficulty controlling their drool. Also, if they are unable to communicate with their parents or caretakers, speech therapy can provide alternate methods of communication. There is the option of surgery. There is rhizotomy, which can target specific neurons that either are overexcited or they're not accepting GABA, and so you can kind of silence those neurons through a procedure called a rhizotomy. Again, not ideal, as is this other surgeries where with patients that are suffering severe pain due to contractures, you can go in and cut the tendons and allow the pressure to release from the forearm or the leg where those contractures have occurred. Again, though, once you have cut those tendons, it's not possible to flex. So it's not an ideal situation, but if the person's suffering severe pain due to their contracture, it may be the only option. Then there's also medication, so we're looking at baclofen or Valium. Baclofen is a GABA derivative, whereas Valium enhances the effects of GABA by acting on the GABA-A receptor. So again, both of these help to enhance the inhibitory neurotransmitter GABA. So what are some current studies that we're looking at? Basically, since there's no cure yet and no ideas as to how to cure cerebral palsy, a lot of the research recently has focused on characterizing the many different symptoms and many different motor deficits and movement disorders that are associated with cerebral palsy, also the prognosis, how can we improve the lives of children or adults with cerebral palsy, also early diagnosis. Some kids are not diagnosed with cerebral palsy until they're 3 years old. Is there any way to develop a test that would help to indicate the presence of cerebral palsy earlier? And then also the various impairments resulting from cerebral palsy and characterizing those impairments. So these are all examples of studies that are currently going on or have occurred in the past. So another important thing to focus on is the organizations that support cerebral palsy. March of Dimes supports fetal child development in general, but they also focus on cerebral palsy. There's the Cerebral Palsy International Research Foundation, the United Cerebral Palsy Group, and then Reaching for the Stars. All of these are also reliable sources of information about cerebral palsy. And then, interestingly enough, cerebral palsy, as I've mentioned before, doesn't always cause major deficits. So these are all examples of individuals that have cerebral palsy, but have led normal lives. And so what you'll see is we have Miss Curran, Abby Nicole Curran. She was Miss Iowa for Miss USA in 2008. And then you have Bonner Paddock. He's pictured there with a young child that has cerebral palsy. He climbed Mount Kilimanjaro, even though he was diagnosed with cerebral palsy at age 11. Then over here on the right, with the guy looking up at the microphone, that's Josh Blue. He was named winner of the Last Comic Standing in 2006, and he based all of his jokes on his condition, which is cerebral palsy. And then you have over here on the left, Stephen Hopkins. He signed the Declaration of Independence and was noted to have cerebral palsy, and he's quoted as having said, "My hand trembles, but my heart does not." So these are famous people that have cerebral palsy that to us or to society may not look as if they have any motor deficits, but in fact do. So they represent one side of the spectrum, the side of the spectrum that we may not be aware of today. This is a picture of me at Fe y Luz in Santo Domingo, Ecuador, when I went down to serve as a medical interpreter. This picture of a patient here. She does have cerebral palsy and is receiving treatment. Notice that her mother is there in the picture, along with a student from the University of Kentucky and a physical therapist from Fe y Luz. The important thing to note here is that in Ecuador, it's not always, our society does not look well on children that have developmental or mental disorders. And so the fact that her mother is here with her and is working with the physical therapist to learn treatment is a major milestone. And so this is a really important clinic in Ecuador to help these children that might otherwise be overlooked by society. So these are the references. Notice here these are all journals or publications, but then I have also websites as well. So I hope you enjoyed the lecture. Please stay tuned for my lecture on traumatic brain injury that's going to be here coming up soon.